Hi, I'm Sammy Sexton, and today I'm going to be talking to you about the deaf and hard of hearing in regard to exercise. So first I just want to explain what the difference is between being deaf and hard of hearing. Deaf refers to an individual with little to no functional hearing and who often uses sign language to communicate. Hard of hearing refers to individuals who have mild to moderate hearing loss and may communicate through sign language, spoken language, or both. The different degrees to hearing loss is based on how loud you need sounds to be in order to hear them. And this is measured through decibels, and here's just a little chart of hearing loss range. So why is this important to us exercise scientists? It's estimated that about 31.5 million Americans have some form of hearing loss, with about 738,000 with hearing loss at a severe to profound level. ASL is actually the third most common language in the United States. Evidence has shown that both children and adults who are hard of hearing or deaf tend to report higher incidence of being either overweight or obese when compared to their counterparts. Of the population considered deaf in the U.S., more than half of them are over the age of 65. Some adults with hearing loss have an increased fall risk, but I will get to that in a little bit. So how does deafness occur? A deaf individual can either be born deaf, which is congenital deafness, or they can experience something that leads to them becoming deaf, which is acquired deafness. There's three main categories of hearing loss: sensorineural, conductive, or mixed. Sensorineural hearing loss occurs when there is damage to either the hair-like cells of the inner ear or the auditory nerve itself. This is the most common type of hearing loss because one of the causes is just normal aging. It can also be caused by loud noise exposure, and this affects both the loudness and clarity of sounds. Conductive occurs when there's an obstruction or damage to the outer or middle ear and prevents sound from being conducted to the inner ear. This can be caused by extreme air pressure changes, ear infection, abnormal growths, swimmer's ear, etc. This affects the loudness of sounds, but not the clarity. And finally, there's mixed. This is any combination of sensorineural or conductive. And this commonly occurs when the ear sustains some sort of trauma. So does deafness affect exercise response? In general, the only physiological difference between a hearing individual and a deaf individual is the impairment of the ears. So, therefore, being deaf has no abnormal effect on exercise response. However, some types of deafness may actually affect one's dynamic balance and spatial orientation, specifically the sensorineural hearing loss. As I mentioned earlier, sensorineural hearing loss is when there's damage to the inner ear. And that makes sense because the balance is also associated with that inner ear. So how does exercise affect deaf individuals? It's pretty much common sense, but exercise benefits deaf individuals the same as it would with hearing individuals. As I mentioned previously, those with that sensorineural hearing loss, if you have the right exercise prescription, it may also help improve with your balance and spatial orientation as well. And here are just some general benefits of regular exercise, like reduced risk of falling, reduced risk of obesity, improved cardiorespiratory and musculoskeletal fitness. We all know these. So safety is extremely important. You should make sure that your client is oriented with all aspects of your environment, including all of the emergency exits. The facility should also be equipped with strobe fire alarms, and this is important because you can't just rely on them seeing everyone else freaking out and not knowing what's happening. Also, another really important thing is to make sure you go through some basic cues before actually starting any of the exercises. So you could either learn some sign language from your client, like stop, faster, help, go, stuff like that. Or if they're using their arms during the exercise, then maybe you want to come up with alternate cues, like such as a foot tap, like 1 tap for help, 2 taps for I'm all good. It's also really important to use appropriate communication strategies. You should make sure to speak with your client in a respectful rather than patronizing manner. Also, make sure you maintain eye contact when you're speaking to them. If they have an interpreter helping to translate what you are saying to them and they're looking at the interpreter, it's still considered rude if you're looking at the interpreter. So make sure you stay looking at your client when speaking to them. And this kind of goes hand in hand, but make sure you're facing your patient as well when you're speaking to them, because if they're trying to lip read your lips and your face is over here, it makes it kind of impossible. Also, try not to over-enunciate or yell slowly to them. That kind of goes with the whole patronizing manner of speaking to them. It's just considered rude and annoying, basically, so just try to speak normally. Maybe articulate your words a little bit more, but nothing too major. So for my case study, I chose a woman named Susan, and she is 70 years old, and I chose her age to be 70 because, as I've mentioned previously, over half of the deaf population in the US is over the age of 65. And she has a BMI of 26. Her resting blood pressure is 128/84. Her fasting blood glucose is 90. Her total cholesterol is 196. Her HDL is 74. Her LDL is 110. She is a non-smoker, no family history, and she used to play soccer with her friends in high school and college. Her resting heart rate is 95, and her max heart rate is 142 beats per minute. Her goals are to go on weekly walks with her friends. Right now she can't because she becomes out of breath and needs to stop quickly. She also fell a few months ago and would love to reduce her risk of falling again. And finally, she wants to shed some fat and increase her range of motion. So her risk factors are her age, and her BMI is a little bit overweight, and also her LDL is a little high. It shouldn't be above 100. So this puts her at a moderate risk level. So for exercise testing, I would have her do the 6-minute walk as an aerobic test, which she just walks as far as she can for 6 minutes, and we monitor and collect oxygen saturation, heart rate, and RPE. For flexibility, I would use a goniometer to measure her range of motion at various joints of her body. For the resistance test, I would just use the senior fitness test. This includes a bunch of different aspects, but it's good for seniors. And finally, for balance, I would use the Romberg test, which is when she just stands with her arms either to her side or crossed, and she does it once with her eyes open and once with her eyes closed. And here is her exercise prescription. I mentioned up in the top that intensity is based on a perceived 10-point physical exertion scale ranging from 0 being an effort equivalent to sitting to 10 being an all-out effort. For her aerobic exercises, I am having her do them 30 to 60 minutes a day, at least 5 days a week. And the intensity should be at about 5 to 6 RPE. Some exercises she could do are aquatic exercises, stationary cycling, or treadmill walking. These are not just any, she shouldn't just do these. These are just some examples. As ACSM guidelines point out, it can be any modality that does not impose excessive orthopedic stress. So basically not like running. Resistance exercises, she should do 20 to 30 minutes a day, at least twice a week, at an intensity of about 3 to 4 RPE. And some examples of these exercises are wall push-ups, seated overhead press with dumbbells, or stair climbing. For flexibility, I'm having her do that at least 3 days a week, and she should hold that stretch for about 30 to 60 seconds, and she should feel that stretch at a slight discomfort. And some of these exercises include cat-cow stretch, overhead side stretch, shoulder stretch, and calf stretch. And finally, for balance, I'm having her do this at least 4 days a week because she's both deaf and an older woman. And she also wants to reduce her risk of falling. And she should do this about 20 to 40 minutes per day. And some types of exercises she can do are static balance, which is weight shifts, single leg stance, back side leg raises, and Tai Chi. And for dynamic, heel to toe walking and hip circles. She could also do Tai Chi, I'm pretty sure. And I would also encourage more dynamic balance, especially. And some modifications and special recommendations I have. It's communication can be really difficult at times, and even the most proficient lip readers can only pick up about 30% of what's being spoken to them. So to make sure you have effective communication, you should modify your means of communicating with them by maybe a pen and paper or a whiteboard. Also, make sure that you demonstrate exactly what they need to do from start to finish, or you can have someone else demonstrate it. Or you can have them watch a video of what they need to do, preferably one with closed captioning though. And I also included modifications and special recommendations for individuals 65 and older because, as I've mentioned, over half the population of deaf individuals are over 65. So this includes intensity and duration of physical activity should be light at the beginning. For strength training involving use of selectorized machines or free weights, initial training sessions should be supervised. Incorporating behavioral strategies such as social support, self-efficacy, the ability to make healthy choices, perceived safety, all may enhance participation in regular exercise. Also, they should gradually progress to higher intensities and frequencies. And these are my references. Thank you.